So let us start our today's class. So this class is very important because every paper definitely, so one or two questions regarding HIV will come, and also I think TB is also covered by the Shaja madam, I think. So we just cover the TB topics in relation to the HIV also. So right. So what we have to do, what we are dealing in the HIV, we will see now. Right. So when you take HIV, which is retrovirus, so what are things they're asking is basic, before going to the depth of the HIV topics and all, the first thing we'll discuss is structure of the HIV and life cycle, which was not usually they won't ask this one, but we'll know this thing. Based on that you can know. So different things you can deal, life cycle, and also it's how to do lab monitoring, how to do drug therapy and all. So we'll just see first by going with the structure and life cycle. Then after that and all, what they're asking is how do you lab monitor, lab diagnosis, how do you diagnose this HIV infections, right? Then what the next question they're asking is how do you treat HIV infection, and one important thing is classification of antiretroviral drugs and also side effects and toxicity is very important, right? And after this what they're doing is drug resistance, very important question. What is the drug resistance, what is called treatment failure, and what will you do in such case of drug resistance, and what will you do in such case of treatment failure? That's one more important question they're asking, right? Okay. Then one more important thing is HIV plus TB. This is one more important topic, right? And then comes other important is iris immune reconnaissance syndrome. This is one more important topic, right? And then okay, any doubts, any problem? Somewhere audible, audio problem, any issues is there? Is it clear? Audio is clear now. Mic testing. Okay. Both of you cannot hear the audio?
Sir, I can hear and I am using earphones, sir.
Okay. So what could have happened then?
But initially when it started or when I joined, I also was not able to hear.
Okay.
But after some time, I started hearing.
So Dr. Shilpa, just try once again. Is it my problem or from here this side? Right, just see if it's not audible, we'll again restart the session. So iris is one more important topic they're asking. HIV plus TB co-infections, one more important topic they're asking. And what is the specialty in the case of pregnancy? How will you treat in pregnancy? And what is post-exposure prophylaxis? So entirely this entire is our HIV topic. All these things are they're asking. And different organ manifestations that we discussed before only. So what are organ man we discussed? That also what we'll deal the things. Is it audible now, Dr. Shilpa Patil? No. Hello, is it audible? Can we go ahead? So what we discussed in the first slide is actually the HIV. Before talking about HIV, the number of questions they're asking HIV. Every year one different question will be there. So what they're asking mainly is lab diagnosis. How will you diagnose HIV infections in case of adults, and also what is the treatment strategies you're using, and what are the different classification of antiretroviral drugs, and what are the different side effects they're asking, and then what is drug resistance and what is treatment failure, how are you going to approach to the patient of drug resistance, and what is the HIV plus TB co-infection, iris, and then comes your pregnancy TB, and also in post-exposure prophylaxis and different organ manifestations, right? So all these things in a nutshell will cover the HIV topic. So just it will be one class, you will completely know about HIV and all, right? So before going to deal this thing, we just need to know basic information regarding the HIV structure and also life cycle. We'll just complete the HIV structure and life cycle in just 2-3 minutes. Then we'll go on to the topics, right? Right. Let us begin our session. The first thing is right. The first thing is HIV structure and life cycle, right? So when you see HIV, you already say single stranded RNA virus. It has 2 single stranded RNA virus. We already, it's a 2 viruses. It's a 2 RNA are there. It's a 2 single stranded RNA virus. So what is going to happen is this is what is called as your 2 RNAs, right? It is there and comes a nucleocapsid, right? Then comes it has one more layer, it's protein layer. Then comes lastly it has what is called as your envelope. It contains an envelope, right? And this envelope contains 2 proteins, very important. One is called as, these are 2 proteins are there completely. So this protein is called as GP41 and this round is called as GP40, right? So 2 RNA are there, contain nucleocapsid, protein layer, and this protein layer is formed by what is called as antigens. One is called as P17, P24. These are nothing but your structural proteins, P17, P24, very important, right? So this is the basic structure, and in case of basic introduction about the structure, this is what you have to know. A 2 single stranded RNA are present, enclosed in nucleocapsid containing a protein layer, and this protein layer mainly made by antigens called as P17 and P24, and apart from there is a complete envelope is there containing some proteins are the GP41 and GP120, right? GP41 and GP120. Right? Okay, so this is the basic structure. So after knowing the structure, you can go for what is called as life cycle. So let us don't go much detail into the life cycle. So some important points we want to discuss, which is clinically relevant. Why you have to know life cycle, which is clinical, we'll discuss that thing. So when you come to life cycle, what is going to happen is, once first ever HIV somewhere from the blood or somewhere from the needle stick injury or sexual contact, HIV virus get inoculated into our body. The first thing is HIV inoculation into our body. Into the body. So what will happen is, wherever the HIV virus get inoculated into the body, it will stay in the local place for 3 days, right? It will stay in the local place. It will stay at the local place, very important, for 1 to 3 days, right? It won't reach into the blood circulation. Wherever it is, just stay in the local circulation, local space for 1 to 3 days, right? After this, what is going to happen? Your antigen presenting cells will come into picture. Antigen presenting cells. So what are the antigen presenting cells here? They are dendritic cells. They are dendritic cells. Right? So these antigen presenting cells, they will carry this HIV virus. They will carry this HIV virus. So usually antigen presenting cells, they will engulf the virus and take to the certain organ. But here this antigen presenting cells, they do not engulf this thing, they just carry this thing. Means what will happen here? So this is this antigen dendritic cell, this is a dendritic cell, right? So this dendritic cell will carry your HIV virus, will carry the HIV virus. It will not engulf, it will not phagocytose, it will just carry the HIV virus, right? So after carrying, where will take it? It will take to what is called as lymph node. It will take to what is called as lymph node, right? So in the lymph node specifically, they are called as CD4 lymphocytes are there. CD4 lymphocytes are there, right? And now this HIV virus will bind to the CD4 lymphocytes. HIV virus will bind to CD4 lymphocytes, right? And this binding is very important here. The how it is binding it, for example, this is your CD4, this is your CD4, right? Right? And now comes your HIV virus here. This is your HIV virus, which contains your GP120 and GP41, right? So what will happen is, first it will bind to the CD4 lymphocyte, right? So once it will bind to the CD4 receptor, what is going to happen is, it will bind to the CD4 receptor here. Okay. So after binding to CD4 receptor, there are certain chemokines are there. These are CCR5 and CXCR4 chemokine receptor. Okay, CCR5 and CXCR4 chemokine receptor. Right. So once the HIV virus binds to the CD4 lymphocyte, there are certain chemokine receptors. Other one is called as CCR5 and CXCR4. They will help in stabilizing this bond. Right. So once this bond is stabilized, now what will happen here is, this GP120 will become conformational change. So because of that, it will just open up like an umbrella. It will just open up like an umbrella, and it binds completely to this CD4 lymphocyte, right? After this open up, it will make a pores in the CD4 lymphocyte. So through this pores, now virus enters into the cell. So clear? Come again, we'll discuss again. So HIV first binds to what is called CD4 lymphocyte, right? So once binding to CD4 lymphocyte happens, what will happen is, there are chemokine receptors are there. There are chemokine receptors are there, right? And these chemokine receptors are CCR5 and CXCR4. Right? So these bind to the HIV virus and will strengthen the bond. They will strengthen the bond. Right? So once this happens, the conformational change happens in the GP120. Conformational change in GP120. It opens up like umbrella. It opens up like an umbrella. It opens up, right, and makes pores on CD4 lymphocyte. Right? So after making pores, now the virus will enter into CD4 cell. Enters into the CD4 cell. Right? Enters inside the CD4 cell. So now after entering into CD4 cell, what is going to happen? This virus contains one enzyme called as reverse transcriptase. So this reverse transcriptase will convert the viral RNA into DNA. Reverse. We discussed in hepatitis B also. So transcription is from DNA to RNA. Reverse transcription is RNA to DNA. Right? So once this is done, this virus also contains one more enzyme called integrase. So what this integrase enzyme will do? This integrase will integrate viral DNA into host DNA. That means into host DNA. Right? So because of using this integrase enzyme, this viral DNA will come combined with the host DNA. Right? Now after this, what will happen? After this, what is going to happen? So now this viral DNA and host DNA, they together they form transcription. They form number of mRNAs and they form number of your viral proteins. The number of viral proteins. Right? And all these viral proteins are immature forms. They're activated by what is called as protease. They're activated by one more enzyme called as protease. Right? Now all these activated proteins, they assemble and form new virions. Right? And these virions go out of the cell. Right? So this is the basic life cycle of the HIV virus, very important here. So again, once again we'll go through this. So what is going to happen here? So first of all, HIV, once virus get inoculated to local site, it will stay in the local site for 1 to 3 days. Very important. Right? So it just stay there at 1 to 3 days. Then our antigen presenting cells will come, the dendritic cells. They will attach to the HIV virus. They won't engulf them. They won't phagocytose them. They'll just carry the HIV virus and go to where? Lymph node. Right? They'll go to the lymph node. In the lymph nodes, they're called CD4 lymphocytes are there. Right? In the CD4 lymphocytes, this HIV virus binds to the CD4 lymphocytes. So once they bind to CD4 lymphocytes, there are two chemokine receptors called CCR5 and CXCR4. Right? So they will strengthen this bond. So once this bond is strengthened, now this GP120 will become conformational change and opens up like umbrella, and it tightly binds to your CD4 and make pores on the CD4. So through these pores, now the virus enters into the cell. Right? So once virus enters into the cell, there are two enzymes important. One is reverse transcriptase, which will make your viral RNA into DNA. Now the integrase enzyme, which will assemble this DNA into host DNA. Right? Now this DNA is transcribed, so number of proteins are formed, and these proteins are immature forms. They're activated by the enzyme called again protease. Very important. Right? And all these active proteins, they assemble and form a virions, and these virions will enter out of the cell. So this is the basic life cycle. Clear? Right? So why this cycle is important, very important, I will let you know later. So here one important clinical points we need to discuss here is, so as we discuss, this HIV is inoculation into the body, it will stay in the local site for 1 to 3 days. This point is very important because this is the reason why you have to give post-exposure prophylaxis for 72 hours. Within 72 hours you have to give. Right? So why we are giving post-exposure prophylaxis within 72 hours is because the virus stays in the local site for 72 hours. For 1 to 3 days. After that, virus won't stay in the local site, it will enter into the bloodstream and also difficult to control. So post-exposure prophylaxis will have to start within 72 hours. Right? Okay.
Sir, that previous slide you shown, no?
This one?
Sir, state, local site, after that what you have written?
For 1 to 3 days, and these are antigen presenting cells. These are antigen presenting cells, the dendritic cells.
Okay, sir. And this is next point is this.
So this just they carry this dendritic cells, they carry this virus to the lymph node.
Okay, sir.
Yeah. So it's a pen problem, is there? Okay. No, it is fine. Right? Okay. So the clinical point is post-exposure prophylaxis, you have to start within 70 hours because the virus stays in the local site for the 1 to 3 days. Right? Okay. So this life cycle again will come again. Right? So in short, if we discuss what is called as life cycle here, so what is going to happen here? HIV virus is there. It gets inoculated to local site. After inoculation, it is carried by the dendritic cells, it is carried by the antigen presenting cells. So after carrying, what is going to happen? It will go to lymph node. In the lymph node, it is binding to CD4 lymph node by using what is called as GP120 and also using what is called as CXCR4 and CCR5, right? And this entity is called as this binding to CD4 lymphocyte using this chemokines and all is called as fusion. This is called as fusion. Right? So after this is happening, we already discussed. So once virus binds, it will enter into the cell. Once it enters into the cell, it uses its enzyme reverse transcriptase. By this, DNA is formed. Then after this, virus uses enzyme called integrase. So by this, it integrated to the host DNA. After integrase again, it will form number of proteins. All these proteins are immature. They are getting activated by protease. Right? And after this protease, the multiple variants form. They will assemble and release out of the cell. So this is the basic normal life cycle. Right? So if you see here, there are certain steps are important. One is called fusion, other is called as reverse transcription, other is called integration, other is called as protein cleavage protease. Right? So based on this only we developed drugs to fight against this virus. One group of drugs are called as fusion inhibitors, other group of drugs are called reverse transcriptase inhibitors, other group of drugs are integrase inhibitors, other group of drugs are protease inhibitors. Total 4 classes of drugs are there. Simple. So if you know the life cycle, drugs are very easy. Right? So fusion inhibitors, reverse transcriptase inhibitors, integrase inhibitors and protease inhibitors. Simple. So these are the 4 classes of drugs which are used in HIV. So this is only the asking for the classification. We'll discuss about this so much in the thing. So we'll just complete this, just revise this thing. Completed. So one is called HIV structure. Basic structure is single stranded RNA. 2 RNA are there enveloped in a nucleocapsid. It contains a protein and this protein is made by P17 and P24. Very, very important. P17 and P24 antigens. Right? After it contains a capsule. In this capsule also contains 2 proteins. One is GP41 and GP120. Very important. Right? So HIV always inoculated to the body. After inoculation, it stays in that part of body for at least 1 to 3 days. That's why post-exposure prophylaxis can be given until 72 hours. After that, antigen presenting cells will come, dendritic cells will carry the virus. They won't engulf, they won't phagocytose. They'll just carry like this and go to the lymph node. In the lymph node, they'll bind to the CD4. This fusion is made by your CXCR4 and CCR5 chemokine receptors also. Right? After this conformation change of GP120 happen, it will open up and it make pores in the CD4 and enters into the cell. After entering into the cell, what is going to happen? There is nothing but your reverse transcriptase, DNA is formed, then integrase, it will integrate into the host DNA, then they undergo transcription, form number of proteins, all these are immature forms, then they activated by action of enzyme called protease, then they assemble and they form virions and they released out of the cell. So to combat the virus, we just discussed 4 group of drugs. One is fusion inhibitors, reverse transcriptase inhibitors, integrase inhibitors and also protease inhibitors. I think it's very easy to remember the drugs right now. Right? So we go much detail into the drugs and all later. So next important part is how do you diagnose HIV infection? How do you diagnose it? Very important. How do you diagnose HIV infection? So this is one important 4 marks or 5 marks question. How do you laboratory diagnose of HIV infection? Right. So laboratory diagnosis HIV infection. So the first important point is, before and all they used to think HIV is a very, very complete emergency. It's just a complete, if a patient has got HIV, the patient is going to dead. But it's not. Now HIV has become a chronic manageable disease. Chronic manageable disease. Chronic manageable disease. So this term is very important because chronic manageable disease. Why? Because it became a chronic disease and we can manage this disease based because so many drugs are there and so many early detection are there. And this became a chronic manageable disease because of your early detection techniques. Early detection techniques. Right? So when you discuss about how to diagnose, how to do laboratory investigation, how to diagnose HIV in the case of lab, we need to know one important point. So in the case of if any maternal mother is any HIV positive, for example, mother is HIV positive, mother HIV positive. Then from maternal to fetus, some antibodies are transmitted to the fetus. This is called vertical transmission. Maternal transmission of antibodies from mother to fetus. Right? And these antibodies will stay for 9 to 12 months up to last maximum 18 months of age. Until you're 18 months of age, you can find these antibodies. So why this important point is important? Because for until 18 months of age fetus, you cannot check antibodies because already antibodies are there in the child's serum. So clear, this point is clear. So one important point is, in the case of vertical transmission from the mother to the fetus, these antibodies are getting transferred. Right? These antibodies will stay in the infant serum for at least 18 months. So 12 months or maximum 18 months. So until 18 months, you cannot check antibodies for detection of this HIV disease. Right? So what I'm saying is, so to diagnose HIV infection, you have multiple tests are there. To diagnose multiple tests are there. Right? And all these tests include, you can detect either antibodies or you can detect either antigens. Right? So antibody detection is called as ELISA technique. Right? Antigen detection is multiple antigens are there. Either you can do P24 antigen, P17 antigen, or different antigens are there, or you can directly go for HIV RNA PCR. HIV RNA PCR. So the different tests, antibody you can detect, antigen detect, or HIV RNA PCR you can detect for detection of lab diagnosis of HIV. So one important point is the antibodies that are transferred from the mother to child, they stay for at least 18 months. So therefore, before 18 months and all, you cannot use antibodies for diagnosis of HIV. So after 18 months only, you can use those things. So based on this, I can say one thing. So for lab diagnosis HIV, I can classify individuals as more than 18 months or less than 18 months. Right? Right? So more than 18 months means we can use antibody technique, that is ELISA. Right? So these are called rapid diagnostic tests. These are called rapid diagnostic tests. We are just checking the antibodies in the serum. They are called rapid diagnostic test. Right? But for the case of less than 18 months and all, you cannot use these antibodies because already antibodies are there in the fetal serum. So you have to check only what is called as total nucleic acid PCR. That is very, very important. Total nucleic acid PCR. So this is investigation of choice to detect HIV in individuals of less than 18 months of age. Right? Simple. This is the basic difference. So in order to diagnose laboratory diagnose HIV and all, you have to see the age if patient is more than 18 months or less than 18 months. If more than 18 months, you can do your rapid diagnostic tests are there. So which detects antibodies in the serum. But in the case of less than 18 months, you cannot check for the antibodies because antibodies are already present in the fetus serum. So you have to go for the total nucleic acid PCR. This is very, very gold standard. Right? Right. So let us go for one by one. The first thing is greater than 18 months of age. That is our adults. That is our us only. For adults, right? As we discussed, we are doing what is called as rapid diagnostic test, right? So what is this rapid diagnostic test? You are just checking what is called as antibodies in the serum by using ELISA, right? And these antibodies are directed against different antigens. So any antigen like P24 antigen, right, P17 antigen or any antigen. So they are directed against any antigen. So different tests are there. Main theme is we are identifying the antibodies in the serum. Right? Right. Right. And now this NACO guidelines, they gave 5 different strategies, some strategies for lab investigation, lab diagnosis, right? So the strategies are strategy number 1, strategy number 2, in the 2 again 2A, strategy number 2B, and strategy number 3. So they just give different strategies. So the first strategy they'll use for screening purpose. So strategy for use for screening purpose. So for screening purpose, they'll use some strategy. For surveillance purpose, they'll use 2A. Okay. For symptomatic individuals, they'll use 2B. For asymptomatic individuals, they'll use 3, not 5. Okay. So simple. So for lab diagnosis, so NACO guidelines are given certain strategies. We have to follow those strategies. So those strategies are given to 1, 2A, 2B, and 3. So one first strategy used for the screening, 2A used for the surveillance, 2B used for the symptomatic individuals, and 3 used for the asymptomatic individuals. So for us, the important thing clinically is 2B and 3. So how do you going to assess? How do you do lab diagnosis in individuals who are symptomatically positive, or how do you do lab diagnosis in asymptomatic individuals? So 2B and 3. So this is for just only for the theoretical question and all. So what is the strategy used for this symptomatic 3, and what is the strategy used for the symptomatic is 2B. So right. So let us go for the symptomatic individuals. Symptomatic individuals. Right. So what we are using is strategy number 2B. Just a theory point, you have to remember this thing. So what we are doing is, first, for example, any patient is symptomatically positive. For example, patient is having some symptoms like weight loss, is there, diarrhea, is there, fever, is there, low grade fever, right? If you are thinking that okay, maybe he is some suspecting HIV or AIDS, so it's symptomatic individual, you will do one rapid antigen on rapid test. That is called as test number 1, A1, right? It can be negative or positive. If it is negative, or can be positive, right? If it is negative, yes, done. If it's a negative for HIV, no need to do further test. Negative for HIV, so no need to do any further test, right? Now, if it is a positive, see here confirmation of HIV is very important. So directly just by doing test positive means you cannot say positive. You have to confirm the test, right? Because it's so much of social stigma is there, and again you have to continue using drugs for lifelong, and it's very many opportunistic infections are there. You have to counsel the patient and all. So that's why you cannot say the patient as positive for HIV just by doing single test. Right? You do the first test. If it is negative, yes, it is negative only. Leave it aside. If it is a positive, then go for the second test. Then go for your second test. That is your A2. Right? In the second test again, it can be negative or it can be positive. That means A1 positive, A2 positive. Here is A1 positive, A1 negative, A2 negative. Clear? And second test is positive means A1, A2 positive, second test negative, A1 positive, A2 negative. Right? If in this condition, if patient is positive, A1, A2 positive, he is positive. Report as a positive. Report as HIV positive. Then no need to do again third test. You can report him as HIV positive. Very important thing. Right? Now for individuals who are A1 positive and A2 negative, now you can do one more test called as A3. You can do one more test, that is A3. Right? Now you have two possibilities are there. One is A1 positive, A2 negative, A3 positive. A3 can be positive or A3 can be negative, right? So A1 positive, A2 negative, A3 negative. Right? Now here, so A2 negative, A3 negative, you can report him as a negative person. No need to do anything. Very negative. Right here, but A1 is positive, A3 positive, A2 negative. These are called as indeterminate. Very important. These are called as indeterminate. So for these patients, you have to again repeat at 3 months interval. You have to again repeat after 3 months. So clear? This is what is called a strategy 2B. So why they developed such a strategy is important. So just by doing a single test, you cannot diagnose HIV infection. You cannot declare a patient as HIV. To confirm and to declare a patient as HIV, you have to do multiple tests to confirm that thing. Right? This is called series testing. So developed strategy. This strategy is called strategy 2B. This is used for symptomatic individuals. So again, so what are these A1, A2, A3? These are different tests based on different antigens. So HIV has so many antigens are there. So you have a kits, ELISA kits, targeted different antigens. So first A1 is one antigen. If it is positive, you'll use A2 using different antigen. If it is positive, then you do A3 using different antigen. So they have kits for different antigens. So based on different antigens, you will see whether it's positive or not. If so many multiple positives, then you will declare as positive. So let us revise with this with me. So first, patient is having some symptoms like fever, weight loss, or any diarrhea. All these symptoms are there. So then you are suspecting him as HIV positive. Then you do the first test, that is A1 test. If it is negative, rule out HIV virus. So leave it there. But if it is a positive, rest. If it's a positive, don't declare. Do one more test, that is called as A2 test. Right? If A1 and A2 both are positive, please report him as a positive. No need to go for third test. If A2 is negative, then go for A3. Right? If A3 is also negative, only one is positive, both are negative, it's a negative, report him as negative. But if A3 positive, both are positive, A2 is negative, then you report him as indeterminate. You can again repeat the test after 3 months. Right? So one golden point here is, what you have to remember in this thing is, entire point why we discussed all this thing is, so golden point in this, in symptomatic individuals, right, you can declare as positive if two tests are positive. You can declare him as a positive. No need to have 3 tests are positive, right? If A1, A2 positive, yes, you are positive, declare him as a positive. No need to go for third test. That is important, gold standard point, right? So this is for the symptomatic individuals. Now we'll discuss again one more strategy for asymptomatic individuals, for what is called as asymptomatic individuals. So just 1 minute, I'll just change my pen needed and come. Right, 1 minute. So golden point is one simple one thing. If a patient is symptomatic, you no need to show for the 3 tests as positive. If 2 tests are positive, you will declare him as a positive patient. Right? So now we'll go for the third strategy, that is called asymptomatic individuals. How are you doing lab monitoring? Yeah, okay. Right. So this is for the asymptomatic individuals. Right? So as I already told, what is the strategy we are using? The strategy we are using is your strategy number 3. Right. Right. So here we are using strategy number 3. So here what we are doing, for example, patient is just asymptomatic, like her healthcare workers, we are the healthcare workers, so there are no symptoms, just you want to do your screening test or any OT procedure doing, you want to do any screening procedures. So this is called asymptomatic individuals. So what you are doing here is, first you will do the first test here. that is A1, right? Same A1 here, okay? Right? Again, same if A1 is negative or positive. Negative or positive. If it's a negative, yes, no need, it's a negative only. No need to repeat anything again. Negative for HIV. If it is a positive, again same thing. You go for the second testing, that is A2.
Sir, there was some audio problem. So that asymptomatic, did you tell anything beside that?
Asymptomatic individuals, we are using a strategy called strategy 3. That means any patient, we are healthcare workers or any OT procedures before you are doing this thing. That is for this is strategy 3 we are implementing.
Okay.
Right? Same thing. First you do one test. If it is negative, it's negative for HIV. No need to go for further testing. If it is a positive, then go for the A2 testing. Right? Again A2. Again two possibilities are there. A1 positive, A2 positive. Right? Or A1 positive, A2 negative. Right? In both of this, here one important point is, even though even A1 A2 positive, you won't declare him as a positive. You will definitely do A3. You will definitely do again A3. Right? Here also you will definitely do A3. Right? Now what are the possibilities there? One is all three positive, A1 positive, A2 positive, A3 positive. All three are positive. Right? Or other possibilities, A1 positive, A2 positive, but A3 is negative. Right? In this also same here. A1 positive, A2 negative, A3 positive. Or here again, A1 positive, A2 negative, A3 negative.
Sir, no audio.
No audio?
No audio.
I can hear, sir.
Both
You
of you
can
don't
hear?
have.
Yeah.
Okay, sir.
Both of you no audio. Is it okay?
Yes, sir. Now I am hearing.
Okay. Okay.
Okay.
Right. So what we are saying is, first in the case asymptomatic individuals, do the first test, that is A1. If A1 is negative, he is negative. No need to do any further testing. If he is a positive, again do the second test A2. If both are positive or A1 positive, A2 negative, two options are there. Right? If both are positive, also don't declare him as positive. Again do the A3 test. If you do A3 test, again you can have A1 positive, A2 positive, A3 positive, all are positive, or A1 positive, A2 positive, A3 negative is a possibility is there. Right? Again A1 positive, A2 negative, again you do the A3. Again same A1 positive, A2 negative, A3 positive, or A1 positive, A2 negative, A3 negative. So here the thing is like, if patient is having all the three are positive, then only you will say positive. Very, very important. Positive for HIV. Right? And again, if patient is having only one positive, two are negative, then you declare him as a negative. Right? And other people who is having two positive, A1 positive, A2 positive, A3 negative, or A1 positive, A2 negative, A3 positive, these two are called as indeterminate people again. Indeterminate. So for these people again, repeat after 3 months. Repeat after 3 months. Right? Clear? I am clear? So here the gold standard point here in this situation is, so gold standard is for asymptomatic, to declare him as a positive, all three should be positive. All three should be positive to say him as a positive. That is the only thing. This is what the questions are asking in your SS questions also, or anything also. This is the only thing important. So all this flowchart meaning is this thing. For asymptomatic to say him positive, all three should be positive. Right? For symptomatic to say him positive, two tests should be positive. No need to have third test. That is the only thing. Right? So clear? I think it's clear.
Yes, sir.
Yeah. Okay. So one more important for theory question point of view, one important thing is to do all these tests. Okay. So NACO has given a guidelines where you have to follow 5 C's. You have to follow 5 C's. Right? So what are these 5 C's? The first thing is you have to counsel the patient, right? Then you have to do confidentially, right? You have to counsel the patient, you have to do confidentiality of the patient, right? Right? You have to take the consent of the patient, and you have to do the correct test possible. Okay, you have to do the correct test possible. And after getting positive, you have to connect to the different ART centers. You have to maintain that connection. So this is the 5 C's to do for doing any laboratory diagnosis of HIV. First of all, you have to counsel, you have to maintain confidentiality, you have to take the consent, you do the correct test, then you have to connect to you have proper connection to the different ART centers. So this is what just they're expecting you to write in a laboratory diagnosis of HIV infection. So what is the NACO given? 5 C's. These are the 5 C's: counseling, confidentiality maintaining, consent, and then correct triage test, and also connection to the ART centers. Right? Okay. So this is all about what we discussed is greater than 18 months, that is adult population. So what we discussed, there is also one more entity called as less than 18 months of age. If you go for less than 18 months, so the basic profunda is in less than 18 months, already antibodies are there. Already antibodies are present, which are maternally transmitted. So you cannot use ELISA or rapid diagnostic test. So cannot use rapid diagnostic test. Right? So investigation of choice in these patients is total nucleic acid PCR. Total nucleic acid PCR. So total nucleic acid polymerase chain reaction. That means HIV, RNA only. Right? That's called TNA PCR. Total nucleic acid PCR. Right? So until what time you have to do? So whenever the child presents to you, immediately you have to do. For example, child presents to you 1 month or 2 months you have to do, or at least possible 6 weeks. By 6 weeks you have to do. Right? If the child presents in 1 week, 2 weeks also you have to do, or at least come within minimum by 6 weeks you have to do the TNA PCR. Right? Or if child presents after 6 months, for example, if child presents after 6 months, right? So no need to go for the antibody test. You can go for your rapid test. If this is positive, then only go for your total nucleic acid PCR test. Understand? Right? So child born to the maternally positive HIV positive mother. So whenever you encounter the child, immediately you have to go for doing total nucleic acid PCR test. At least by 6 weeks you have to do it, and you have to confirm whether child is having or not. Right? If child presents to you only after 6 months, then you can do the rapid diagnostic test. If it is positive only, you can go for doing TNA PCR. Right? Or if the child is breastfeeding, right? So through the breastfeeding also, your antibodies and all can transfer, your antigens and all transfer. So what you have to do is, after stoppage, 3 months after stoppage of breastfeeding, you can do your PCR. Right? This is a simple thing. Right? So this is the guidelines they are given. What is the laboratory monitoring and all? So less than 18 months of age, you cannot do the rapid test, you cannot do the check for the antibodies. You have to directly go for the antigen. That is your total nucleic acid PCR you have to do. That is your viral nucleic acid. Right? So when you have to do, immediately after contact only you have to do. Whenever the baby comes to your contact, you have to do, or at least within 6 weeks you have to do and confirm whether the baby is having nucleic acid or not. Right? Because early the start of treatment, early is the that much good is the prognosis. Right? If baby comes to you after 6 months only, you are seeing the baby after 6 months only, then at least do antibody test. If it is positive, then you can go for PCR. Right? If baby is having breastfeeding, then after stoppage of 3 months of breastfeeding, again you have to do total nucleic acid PCR test. Simple. Right? This is what you have to discuss in the case of. Yes.
Sir, your 6 weeks means 6 weeks of birth, sir.
Yeah, 6 weeks of birth. That means whenever the child presents, you have to do immediately. But what they are saying is at least you have to establish the diagnosis by 6 weeks of age, so that you can start the treatment, so baby can be your lifelong immunity can be there.
Okay, sir.
Right? Right. So just numbers only, 6 weeks, 6 months, like that. If baby presents after 6 months, means you have to do antibody test. If antibody is positive, then you can go for PCR. Right? So this is what is the lab monitoring in this thing. So just we'll go through this one of the important 5 marks question to you. Multiple times are asking also, and for NEET assessment also the 2 questions are important, for asymptomatic and symptomatic. Right? So what we are discussing, diagnosed lab infection, is called chronic manageable disease because you have some early detection techniques are there. right? So only important thing is multiple tests are there. Either you can detect antibodies or you can detect antigens or you can detect directly your HIV PCR also, HIV nucleic acid. So lab diagnosis depends upon age of the patient. If it's more than 18 months or less than 18 months. More than 18 months, you can do rapid diagnosis. Less than 18 months, you have to do only PCR, right? So more than 18 months, adults. The important thing is NACO has given certain strategies. That strategy numbers are 1, 2A, 2B, and 3. 1 used for screening, 2A used for surveillance, 2B for symptomatic individuals, and 3 for the asymptomatic individuals. Right? So 1 and 2 not much important. 2B and 3 are very important. So 2B is for the symptomatic individuals. So what you have to do is do the one test positive test. If it is negative, it's negative only. If it's positive, don't report. Again, repeat one more test. If one more test is also positive, then you can report him as a positive. So for symptomatic individuals, 2 tests should be positive to diagnose him as a HIV positive. Right? If 2 also negative, then you can indeterminate. People who are indeterminate, you can go for doing repeat after 3 months. Right? If 2 are negative, you can say as negative only. Simple. For asymptomatic individuals, to diagnose a positive, 3 tests should be positive. Right? If 3 are positive, then only declare him as positive. Remaining this, if 2 are positive, you can say indeterminate, you can repeat after that. If 2 are negative, it's a negative. Very important thing. Right? And what is A1, A2, A3? These are the different tests which uses different antigens or different principles, not the same test. If this A1 test uses P17 as antigen, A2 test should use P24 as antigen. You should not use a P17 only. Right? Through different antigen tests, you are getting positive, then you can strong confirmation is there. Right? So all these things, NACO is given 5 C's. One is your counsel, then you maintain confidentiality, you just take a consent, and then you do the correct test, then you connect to the ART centers. Right? So then comes less than 18 months of age, already antibodies, you cannot detect your rapid diagnosis, you have to do total nucleic acid PCR only. So within 6 months only you have to diagnose the patient, diagnose infant. If the patient comes after 6 months, please do antibodies. If antibodies are positive, you can go for the PCR, otherwise no need. Right? If any breastfeeding is there, after breastfeeding also 3 months after completion of breastfeeding, you have to go for the PCR testing. Right? So this is all about lab diagnosis. Right? One important question. So one important other thing is, after diagnosing, what do you do? How do you manage these patients of this thing? So management will discuss. Right. So simple. Now NACO guidelines has come up with a single line, very important single line. Before and all, there's so much confusion. Is there CD4 count is this much, you have to treat. CD4 count is that much, no need to treat. If who grade 1, you have to no need to treat. If who grade 3, grade 4, you not. That simple, so much confusion is there. Now NACO has come up with everything. Any patient who is HIV positive, treat all. So the strategy we use is treat all strategy. Right? So before treatment depends upon your WHO classification, before treatment depends upon your CD4 count, but now the strategy is treat all strategy irrespective of the patient symptoms, irrespective of the CD4 count levels. Right? So treat, if patient is HIV positive, treat all. Right? So how will you treat? You have called as pharmacotherapy. Right? Right? So in the pharmacotherapy we discussed again already. So what are the different drugs are there? So the different drugs depends upon your life cycle. The first step is virus entering into the cell. So virus will fuse to the CD4, that's called as fusion inhibitors. Right? And after fusion, virus enters into the cell, then your reverse transcriptase comes and forms DNA, that's called reverse transcriptase inhibitors. So once DNA is formed, it will get integrated to the host DNA, integrase inhibitors. Right? After integration, they form multiple proteins, and all these proteins are getting activated by cleavage of protease. You will have protease inhibitors. So these are the 4 major groups of drugs that are available in the case of HIV treatment. Right? So this is again one more question they're asking, just what are the different classifications of HIV drugs. So just see, antiretroviral drugs. So as we discussed, there are 4 groups. One is fusion inhibitors. Right? So what are the fusion inhibitors drugs are there? Other is your reverse transcriptase inhibitors. Other is your integrase inhibitors. Other is your protease inhibitors. Right. So fusion inhibitors, what are the different fusion inhibitors are there? Only 2 drugs are there, very important. It's called as GP120 inhibitor. So this GP120 is called N-fuviritide. Right? ENFUVIRITIDE, N-fuviritide. And another is your CCR5 inhibitor. So all these things are Virok, Mara Virok, Viccrivirok, and Senvirok. Marvirok, Viccrivirok, Senvirok. These are CCR5 inhibitors. Right. Then comes reverse transcriptase inhibitors. So what is reverse transcriptase inhibitors again? We are inhibiting the reverse transcriptase. So this is an enzyme which is helpful for the conversion of RNA into DNA. We are inhibiting these things. So to make RNA into DNA, you require some nucleoside. So these RT inhibitors can be classified into nucleoside reverse transcriptase inhibitors, nucleotide reverse transcriptase inhibitors, or non-nucleoside reverse transcriptase inhibitors. So again, 3 groups of drugs are there. Right? One by one is there. One is called as nucleoside. Right. One is called as nucleoside reverse transcriptase inhibitors. Right. Other is called as nucleotide reverse transcriptase inhibitors, and other is called as non-nucleoside reverse transcriptase inhibitors. So what is the difference here? This is called nucleoside reverse transcriptase inhibitors. Means for RNA to become DNA, you require so many nucleosides. So these are the drugs which resemble like a nucleoside only. So they'll bind to the RNA instead of nucleoside. So the competitive inhibition, that is. And non-nucleoside is they don't resemble like a nucleoside, they cause non-competitive inhibition. Is clear? Right. So reverse transcriptase inhibitors, the 3 groups are the nucleoside, nucleotide, and non-nucleoside reverse transcriptase inhibitors. In nucleoside reverse transcriptase inhibitors, you have drugs like Zidovudine. Yes.
So this nucleoside, nucleotide, non-nucleotide, that naming is how, sir?
What? This, see, reverse transcriptase inhibitors is there. Reverse transcriptase will cause RNA into DNA. Right? So to make RNA into DNA, you require so many nucleosides. Right? It will use some nucleoside and helps in conversion of RNA into DNA. So to inhibit this reverse transcriptase, we developed certain drugs. So some drugs, they will resemble nucleosides. Some drugs, they will resemble the nucleosides. So what will happen? So instead of the nucleoside, this drug will bind to that enzyme. So there is no possible transcription, reverse transcription happens. So these are called as competitive inhibitors. So they are your nucleoside reverse transcriptase inhibitors. Right? And some other drugs, they don't resemble anything. They don't resemble nucleosides. They just go and bind to the reverse transcriptase and inhibit that thing. So they are called as non-nucleoside reverse transcriptase inhibitors. So they are doing here non-competitive inhibition. So based upon the structure, whether they're resembling nucleoside or not. If they're resembling nucleoside, they're nucleoside reverse transcriptase inhibitors. If they're not resembling like nucleoside, they're non-nucleoside. So because they're resembling, they will cause competitive inhibition. Because they're not resembling, they're causing non-competitive inhibition. Right? And nucleotide means, you know, nucleotide and nucleoside. Nucleotide has these 3 things are there. One is your sugar moiety, phosphate group, and again this thing. So all these 3 things are the nucleotide. If only 2 is there, that's called as nucleoside. Right? Based on whether they resemble nucleoside or not, you have 3 drugs.
Okay, sir. Thank you.
Yeah. So what are the different drugs in nucleoside? Zidovudine, lamivudine, emtricitabine, right? Tavudine, and abacavir. Very important. Abacavir is very, very important. Right? So zidovudine, lamivudine, emtricitabine, tavudine, and abacavir. Right? And nucleotide is only one drug is there. It's called tenofovir. Tenofovir. We discussed about this tenofovir hepatitis B, tenofovir diproxyl fumarate, and tenofovir alafenamide. Right? And non-nucleoside are very important again. Here 4 drugs: nevirapine, efavirenz, delaviridine, atraviridine. Right? So nevirapine, efavirenz, atraviridine, delaviridine. At least you have to remember those 2: nevirapine and efavirenz. Very important. Right? Okay. Then comes integrase. Integrase means actually there we are discussing actually this host DNA, this viral DNA becomes integrated in host DNA where it inhibits integrase. There are only 2 drugs, very important: dolutegravir and raltegravir. Dolutegravir and raltegravir. All these things they have gravir. And the last protease. Protease is an enzyme which is required for the cleavage of the proteins and making active. So we are inhibiting that enzyme. The protease inhibitors are again lopinavir, ritonavir, saquinavir, donavir, atazonavir. So all the number atazonavir, avir. So the simple remember is NSR is all jitavudine, lamivudine, stavudine, like that will come. This integrase inhibitors are dolutegravir, raltegravir, gravir will be there, and protease inhibitors are lopinavir, ritonavir, avir will come. Right. So this is the classification of antiretroviral drugs. They're asking this also. So just a 5 marks question they're asking. Right, simple. So nothing to mug up also. Simple. This is based upon your life cycle. You have 4 classes of drugs. One is fusion inhibitors, reverse transcriptase inhibitors, integrase inhibitors, and protease inhibitors. Right. So fusion inhibitors are GP120 inhibitors and fuviritide. Right. And CCR5 inhibitors Marviroc, Vicroviroc, Senviroc, Viroc. Right. And reverse transcriptase inhibitors. And this reverse, we are inhibiting the reverse transcriptase. So these drugs can resemble the nucleosides or cannot resemble the nucleosides. If they are resembling the nucleosides, they are nucleoside reverse transcriptase inhibitors. If they are not resembling, they are non-nucleoside reverse transcriptase inhibitors. Right? If they are resembling means they will cause competent inhibition. If they are not resembling, they will cause non-competent inhibition. So drugs are jitavudine, lamivudine, emtricitabine, stavudine, dedanocin, abacavir. Right? And nucleotide is only one drug, tenofovir, and non-nucleoside is nevirapine, efavirenz, atraviridine, delaviridine. Right? And integrase are dolutegravir and raltegravir. And protease inhibitors are lopinavir, ritonavir, saquinavir, donavir, and atazonavir. Right? So this is a classification of ARV drugs. Right. Right? Okay. So before going to these things, one or few points regarding one drug is important. One is N-fuviritide. So as I discussed, tide is always a peptide. You cannot give orally. It's a subcutaneously given drug. It's the only parenteral HIV drug as of now. Right? But there are 2 more parenteral drugs that are approved, but they didn't come in any guidelines. They will come also. The 2 parenteral drugs, we'll discuss about it later. So one is N-fuviritide, it's subcutaneous. It's a peptide. You can have it subcutaneous. It's a parenteral HIV drug. Right? And then next comes about these things. This Marviroc, Vicroviroc, nothing to discuss about. This is CCR5 inhibitors, fusion inhibitors. That's it. No need to remember about these things. Right? And then comes your nucleoside reverse transcriptase inhibitors. Right? Right. All these things, they share a certain side effects, very important. That is, they cause mitochondrial damage also. And they lead to cause a side effects, spectral side effects called LMNOP. L is for lactic acidosis. M is for myopathy. Right? And N is for neuropathy, peripheral neuropathy. And P is for pancreatitis. So this is the LMNOP side effects of all these things. Right? So what is the drug you take here? All these things will have all these side effects. Right? Apart from them, and certain drugs are important. One is jitavudine. Very, very important. All these points, multiple side effects, but at least these side effects you have to remember, because a antiretroviral drug side is very important for your clinical case also. Recently also in our some tenofovir-induced bone demineralization patient has come. So tenofovir-induced AK has come. So all these things are very important. Right? Apart from these things, jitavudine has one more side called bone marrow suppression. Very important. And that's why it is also caused majorly anemia is the one complication. Right? And then abacavir, very, very important. This abacavir has hypersensitivity side effect. Right? And this hypersensitivity is seen in individuals with HLA B star 5701. This is also very important. Right? So why this is important is, so any patient who is developing some hypersensitive reaction to this abacavir, so any individuals who has this HLA B star 5701, they will definitely develop hypersensitive reaction to abacavir. So these are only less than 5% of individuals. Right? So these patients, when they give abacavir, they will definitely develop what is called as MI because of this hypersensitivity. So that's what very, very important about abacavir. So what I am saying is, abacavir in individuals who is having HLA B star 5701, they will have hypersensitivity reactions. right? So once initially there is hypersensitivity reaction, you should not continue, you should not challenge this drug, you should stop this drug. Otherwise, if you go on keeping this drug, they'll definitely develop MI. So that is why in US and all, what they will do is before giving abacavir, they'll do this HLA booster 5701. If it is positive, they will strictly contradict this drug. But in India, what we'll do is we'll give the drug initially. If the patient develop any hypersensitive reactions like normally hypersensitive reaction and all, you will never give this drug. You will just mention as hypersensitive abacavir, you will never give because they have more chance of developing MI. Very important thing. Right? Right, we discussed enfurotate, Jidabodine, Lamivudine, okay, fine. Okay. Then comes major important drug, that is tenofovir. Very important is tenofovir. Renal failure. Okay, renal failure mainly in the form of proximal tubular acidosis, what is called as Fanconi pattern of proximal tubular acidosis. Right, so mainly it affects your proximal tubular. We discussed this in the case of when you discuss renal tubular acidosis, the type 2, type 1, type 4 we discussed. Type 2 is nothing but the proximal tubular acidosis. The major important drug is tenofovir. Right, so once the proximal tubular acidosis is there, what will happen here? You will have glycosuria. Even though patient is normal, non-diabetic, normal sugar levels in the blood, they will have glycosuria because your proximal tubule is required for the absorption of the glucose. And they also have amino aciduria because amino acids also getting absorbed in the proximal tubules. Amino aciduria, right? And again they will have hypophosphatemia, right? And they have hypokalemia, and they have what is called as metabolic acidosis. So all these things you will see in case of tenofovir because renal failure, mainly renal tubular acidosis, Fanconi pattern because of proximal tubular acidosis. Right? Apart from this tenofovir, one more important point is bone demineralization. Very important, bone demineralization. Right? There are more tendencies to form fractures. So renal failure and bone demineralization are very important things. Right? If any patient of your HIV positive patient comes with any renal failure or anything, if he is taking tenofovir, he developed renal failure, never again continue the drug. Please stop the drug. Okay, see for the alternative results. So never again after giving. If you stop the drug, so if KFT improves, don't again dare to attempt for giving tenofovir again. Right? Important. Right? We discussed tenofovir. Then comes nevirapine, efavirenz. Okay. Right. Not much we'll discuss about these things because you don't use those drugs now. So nevirapine, mainly hepatotoxicity, very important. And efavirenz, it will cause daydreaming, very important, hallucinations. And because Stevens-Johnson syndrome, some patients they will develop Stevens-Johnson and toxic abdominal necrolysis also because of this hypersensitive reaction. These two are very important, right? Any drug which is which is developing Stevens-Johnson syndrome is efavirenz, right? And then comes the hero of the decade, that is dolutegravir, very important. So the entire decade is going with the dolutegravir, right? Right. So dolutegravir, it's a very minimal side effects. Right. One important thing of dolutegravir is it is active against HIV-1 and HIV-2, very important. Right, and it clears viral load within 1 month. Within 4 weeks, it will clear the viral load by less than 50%. Very important dolutegravir drug. That's why now the dolutegravir has become the first line drug in case of ARV management. Right, it will clear the viral load within 1 month by 50%. Right, the two important side effects are very important. Is one is weight gain, very important, weight gain. Right, and hyperglycemia is one more important thing. Right, and last and the final contradicting point, that is neural tube defects. Right, so this is a contradicting point. Why? Because contradicting only in when they do so many studies and all, they find that less than 0.2% of individuals will have neural tube defects with the dolutegravir, but it's not proven completely. right? So that is why when you're prescribing any retroviral drugs to the pregnant ladies, you will counsel the pregnant ladies like this: there's a chance of less than 0.2% neural tube defects are there, but maybe or may not be. If you want to take the risk, you can go on with dolutegravir. If you don't want to take the risk, please stop dolutegravir, we'll give another drug. So it is up to the patient's choice, right? But so many articles has given it's no relation, but one or two few articles they showed less than 0.2%. So it's just a contradicting point. Only weight gain is very important. Neural tube defects, it's a contradicting point again, right? Okay.
Sir, with folic acid also it is cannot be given.
Now we are giving dolutegravir only. We are not giving anything. We are for pregnant ladies also we are giving dolutegravir only. But in the dolutegravir drug itself, they will give you some they will write some precautionary like, okay, it is depends upon the patient. If the patient wants to take also, they can take. If they don't want to, they won't, no need to take. But only thing is why you don't want to remove this drug is this very efficacious drug. It will decrease viral load by within 1 month only. So even if the pregnant lady has come at 32 weeks or something, or 27 weeks or something, that time also if you dolutegravir, it's very effective for preventing transmission to child. So that is why you always prescribe this drug only. But just because of the thing is there, they just say like, okay, just counsel the patient. If they want to take, they will take. That's it.
Okay.
Right. And last about other thing is right. Here one more drug is there, that is indinavir in protease inhibitors. Indinavir. Right. So, and last comes the protease inhibitors. In this protease inhibitors, one important thing is ritonavir. It's a booster drug. So what is booster drug? Actually, when any other drug, if you combine with any other protease inhibitors, if you combine with this drug, the effect of the drug will be increased, right? For example, if you're giving lopinavir drug, you combine with ritonavir also. So lopinavir drug effect will be increased because it's an enzyme inhibitor. The lopinavir levels will be increased. So like it's called as booster drug. That one point you need to remember, right? And atazanavir, it will cause hyperbilirubinemia. That's it. And indinavir, very important, indinavir, it will cause some uric acid stones, nephrolithiasis, uric acid stones, very important, radiolucent stones. That's it. So these are the basic side effects. This is one of the questions they asked: what is the classification of antiretroviral drugs, and name the list of the important side effects. If you don't remember everything also, please do remember the tenofovir, very important. Your clinically also you will see, and your what is called as dolutegravir, very very important. And remaining your NSRTS, they cause mitochondrial LMNOP side effects, right? Okay.
Sir,
Yeah.
I'm studying in private college now, so if usually patient come and get diagnosed, we just give referral to go to the government setup and take the medication.
Yeah.
So what actually the patient receives there?
Yeah. The next session is next slide is that only.
Okay.
Right. So this is the basic so multiple ARV drugs are there. These are side effects are there. This is one of the questions they asked: what is the classification of ARV drugs and what is the different side effects they asked? So that's why we discuss this thing, right? So now, what is the treatment we are giving to the patient? We'll just start with a new slide. Okay. Right. Just give 1 minute. Right. So all these are clear. I'm just erasing these things.
Okay, sir. Right.
So these are different ARV drugs are the different side effects are studied. But what NACO is recommending, if any patient has come with any HIV positive, NACO is recommending what is called as treat all strategy. So whatever the patient it is, treat. If patient is HIV positive, treat the patient irrespective of CD4 count and irrespective of your symptoms. And what do you treat? Your treatment is TLD regimen. TLD regimen, right? So what is the saying? They're saying is you have to give 2 NRTIs plus 1 integrase inhibitor. 1 integrase inhibitor. That is called as tenofovir plus lamivudine plus dolutegravir. TLD regimen. Very important, right? Before this thing, no need to note this thing. Before this thing, what we are doing is we used to use TLE regimen, tenofovir, lamivudine, and efavirenz. That is 2 NRTI, 2 nucleoside plus 1 non-nucleoside. This is what we used to use before, right? Before TLE, we used to use Jedalin, Judavudine, lamivudine, and nevirapine. These are all before they used to use, but all these things they are gone. But only thing now we are using is TLD regimen, right? 2 NRTI plus 1 integrase inhibitors. So tenofovir, this dose is 300 mg. Lamivudine dose is again 300 mg. Dolutegravir dose is 50 mg. Right? It is all these three comes in a single drug, fixed drug combination, FDC. Right? One pill. Take at the night. Take at night. So this is the NACO recommended therapy. So treat all strategy, the therapy is 2 NRTI plus 1 integrase inhibitors, 1 2 NRT is tenofovir, lamivudine, integrase is dolutegravir. So 300, 350 mg. Whoever the patient comes, whatever the patient comes, this is the regimen. So before and all, so much confusion is there. If CD4 count is this thing, who grade 3, grade 4, you have to treat like this. So much is there. Everything is eliminated. Only thing is treat all. So NACO has made it life simple for us. It's a treat all strategy, TLD regimen. So before there's a TLE regimen, before there's Jedalin regimen, before there's so many regimens, all these things are gone. Only thing is this thing, TLD regimen. Right? 300 plus 300 plus 50 mg. It's a fixed dose combination. It's a 1 pill tablet at night. Right. So that's why we have to know about the side effects of tenofovir, because renal failure, bone damage, patients will come. You have to know about the side effects of dolutegravir, weight gain, because so many patients are coming with these things.
Sir, dose of the 3 drugs will also be same.
Yeah, same.
For any CD4 count and any weight of the patient.
Any weight, the same drug. It's a fixed dose combination. There's nothing like mg per kg and all. This dolutegravir exceptions, we'll discuss about it later. But right now 300, 350 mg.
Okay.
Just a minute. Right. So no matter what is the dose and all, everything is same, 300, 350. There is no mg per kg dose. It's always 300, 350. Right? So only thing you have to know about this is tenofovir. Right? It is contraindicated if it is EGFR is less than 30 ml per minute per 1.73 meters cube. Right? So then only you have different combinations. Other we'll see those things. So right, for example, now just see the clinical scenarios. For example, patient has come, right? So patient is HIV positive. So straight away you have to treat as TLD regimen 300, 360. Right? For example, if patient is having AKI, then what will you do? You cannot give tenofovir. Then you can go for, instead of tenofovir, you can give Judavudine. Right? But because Zidovudin again will cause anemia, if hemoglobin is less than 9 grams per dl, you cannot give Zidovudin also. Then you can give abacavir. Very important. That's it. So this is the basic dictum. You have start on TLD only. If any AK is there, you cannot get tenofovir, go for Zidovudin. If any anemia is bone marrow suppression, you cannot get anything. You have to give only abacavir. Simple thing. Right? The gold standard is TLD regimen. Right? Clear? Any doubts? No. Right. Okay. So if any patient is having AK or something, you should not give this. This abacavir also again the same dose. For abacavir is 600 mg. You have to remember abacavir 600 mg. Again lamivudine is 300 mg. Again dolutegravir is 50 mg. Very important. Right. So one more important clinical point, like I already, so for example, patient is taking ATT. For example, patient is having tuberculosis, you are taking ATT also. You know this ATT rifampicin is enzyme inducer. Rifampicin is enzyme inducer. Right. So because of enzyme inducer, dolutegravir, it will metabolize the dolutegravir. So that's why for that patient you have to give, so fixed dose combination TLD you will give 300, 300, 50. Apart from that, you will again extra add dolutegravir, one more 50 mg you will add. One more 50 mg you will add after 12 hours of the first dose. Right? Clear? Understood? So for example, patient is taking ATT, patient is having tuberculosis, patient is taking ATT, he is taking rifampicin enzyme inducer, it will decrease the levels of dolutegravir. So for that we are giving extra dose of dolutegravir, that is after 12 hours of the fixed dose combination you will give. Right? So night he will take the TLD, morning he will take the dolutegravir. Night he will take the TLD, morning he will take the dolutegravir, like that. Extra dolutegravir dose is given. Or one more option is you can convert this rifampicin into rifabutin. That is also you can do, whatever it is possible. But giving dolutegravir extra dose is better. You will give that thing. Right? Right. Right. We discussed about TLD. Then we will discuss about this. If anemia is, if renal failure ZLD, if anemia is there, we are giving ALD and all. We will discuss many things. In case of ATT, instead of this, these things. And second, pregnancy very important. In the case of pregnancy, whatever it is I said, that the gold standard is TLD only. But only thing is, we will counsel the patient. This dolutegravir has a risk of less than 0.2% of neural tube defects. That is also not completely proven. Some controversial doubt is there. You will explain to the patient. If you want to go ahead, you can go ahead. If not, if patient insists like no, I don't want to go ahead, then you can go for tenofovir, lamivudine, and efavirenz. For them, with efavirenz. Right, that's it. For these people, if who don't want to take dolutegravir, then you can go for efavirenz. Right? I told you before this TLE regimen, that regimen uses TLE only. TLE efavirenz only we are using. But because later we came to know dolutegravir is very efficacious, it is decreasing the viral load by 50% within 1 month, we change your regimen to TLD regimen. Right? But still, if patient is not convincing, if she wants much more safer pregnancy, then she can go for TLE efavirenz regimen. But ideally is TLD only. Simple. Right? Right. Right. So after this thing, one important thing you'll discuss. So you discuss lab diagnosis, treatment you discussed, what are the adverse effects you discussed. So after giving what is the major treatment you are given, TLD regimen you are giving, you know the doses also, you know the side effects also. So based upon the side effects you are seeing, one important point is if patient is having some EGFR, you have to change the drug. It's just a basic, if you know the side effects, it's just a basic common sense only. In your SS or also answer questions also, just give the patient scenario only. So based on that, if anemia is there, you cannot give Zidovudin. If renal failure, you cannot give tenofovir. If patient has history of MI, you cannot give abacavir. Like that, based on side effects only, you will rule out the things. Right? So one more important thing. For example, you started a patient on tenofovir. If patient started patient on tenofovir, after some time patient developed deranged KFT. Right? What you can do? Please stop the drug. Once KFT improves, okay, don't restart the drug. Don't restart the drugs. Go for alternative. What is alternative? You can go for Zidovudin, you can go for abacavir. Mostly you will go for abacavir. Right? And the stenopore usually cause a reversible kidney injury, but again if you restart, again it will cause much more irreversible injury. So that's why you don't restart the drug, you will just go for the alternative, especially abacavir you will go. That's it. Simple. Right? Okay, this is all done. Now one more important topic I want to discuss. For example, if you saw the patient of HIV positive patient, then you decided to treat, you start on TLD thing, right? So now they will develop one important risk factor called as iris, which is very important question for you again. Iris, right? So let us see what is this iris. Very important. After starting ART in a patient of HIV positive individual, they will develop a side effect called as iris, and this iris is nothing but immune reconstitution inflammatory syndrome. Immune reconstitution inflammatory syndrome. Immune reconstitution inflammatory syndrome. So what is this thing? We'll see. So what is this thing is, for example, the patient is HIV positive, right? That means all his immunity is gone. Immunity is gone, right? Now you have given patient antiretroviral drugs, right? After antiretroviral drugs, what is going to happen? The viral load will decrease, because antiretroviral drugs, they will decrease your viral load. So once viral load will decrease, your immunity system will improve. Your immune system will improve. Okay. Now this improved immune system will cause damage to your body. Right? Till now your immune system is not active, your immune system is suppressed by the virus, so you are not feeling anything. Once your immune system has improved, it will cause some damage to certain individuals, and that damage because of improved immune system is called as immune reconstitution inflammatory syndrome. Right? So clear? So because of HIV, your immune system is completely suppressed. Right? So once you start taking ARV, your immune system will become improved. Once your immune system is improved, it will see small infections also. Then it will recognize infections. It will cause inflammatory damage, and that damage caused by the reconstituted inflammatory system is called as immune reconstitution inflammatory syndrome. Right? So this is the basic thing. So how will you write basic definition? The definition of the immune reconstitution syndrome definition is simple. Right? So what's the definition? How will you define this thing? Right? So appearance of, it's a worsening, it's a condition of worsening signs and symptoms of known infection. Every line is important. We'll explain this thing. So worsening signs and symptoms of known infection, or developing disease from latent infection. Due to activation of immune system after starting ART. Right? After starting ART. Right? After starting ART within 6 weeks, you will see. This is the important definition. So we'll discuss this definition one by one. Every line is important. So what is the definition? The basic concept is simple. So patient immune system is completely suppressed. Now you have given antiretroviral drugs. Now patient immune system has improved. Now patient is developing some symptoms and signs. Right? And that is called as iris. So what is going to happen? We'll see. For example, if a patient have anti-HIV positive, his immune system is completely suppressed. Right? Now immune system is not able to recognize any infections or something. Now patient has developed some infection, opportunistic infection, but still his immune system is not there. It cannot recognize that infection. No inflammatory process happen. Now you are given antiretroviral drugs. Now his immune system has increased. Once immune system is increased, it will recognize that infection is there, that body is containing tuberculosis. So now it will mount an immune response against the tuberculous antigens. right? So because as it mounts immune response, you will develop the symptoms. That is called as symptoms. So this is called worsening signs and symptoms of known infection or developing disease from latent infection. So what does these two lines indicate? Already patient has some known infection, like for example patient has already tuberculosis there, right? So but patient is already HIV positive, his immune system is suppressed, so immune system is not acting on the tubercular antigens, so patient is not having that much signs and symptoms. Normally some fever is there, okay, like that. But once HIV drugs are given, his immune system is improved. Now this immune system mount an inflammatory response on tubercular antigens. Because of that, patient is developing much more high grades of fever. That is worsening signs and symptoms of known infection. Already patient has a TB, but that time only normal fever spikes are there. But because of activation of immune system, there is the mount inflammatory response, high spikes of fever, worsening signs and symptoms of known infection, right? Or developing disease from latent infection. What does this indicate? The patient had infection, like healthcare workers we had some latent infection. So we don't know that TB infection is there. We don't know the infection. We don't have any symptoms or signs. But after giving your ARV drugs, after your mounting inflammatory response, now you will develop disease. That is called developing disease from latent infection, right? Either latent infection will become a disease, or already known disease will worsen. So after activation of immune system by the ARV, that when will happen? Within 6 weeks of starting ART, will develop this. That's called as immune reconditioning inflammatory syndrome. Is clear? Right? Already patient has some known infection. That infection signs and symptoms are worsened, or patient has latent infection. It has developed a disease after starting ARV because of reconstitution of your inflammatory system, right? And this will develop within 6 weeks of starting ART. So that is called as immune reconstitution inflammatory syndrome. So clear, this definition is clear, then it's very easy.
Sir, like the ART is initiated, the immune system gets reactivated, and then there is worsening of
Yes.
like the patient develops some
what
symptoms.
is the problem is actually when yes.
Okay.
It's a simple thing. Where actually HIV virus is there. So this virus will target your CD4 immune lymphocytes and will damage your immune system. So once you give antiretroviral drugs, your HIV is completely gone. That your viral clearance is there. Once viral load is decreased, your immune system will regain its immune system. So once you regain immune system, then you will develop different signs and symptoms, and that is called as iris.
The signs and symptoms are because of any new infection, sir, or it's just coming because of the treatment?
That's the DD is the new infection. We'll discuss that thing.
Okay.
So they develop after starting ARV, they'll develop some signs and symptoms. So that can be iris, right? Right. So now we discuss what are the different risk factors for developing iris. Risk factors for developing iris. Right. Right. First risk is before starting ART, if patient is having high viral load, right? So what is happening here? The only thing is the major risk factor is if you decrease the viral load at a stage very fastly, and similarly if immune system regains very fast, then only you will develop iris and all. So if patient has high viral load, right, already the immune system is so much suppressed. Once you give your antiretroviral drugs, so suddenly immune system will reactivate and will cause symptoms. So one of the risk factors patient is having high viral load, right? And second thing is if patient is having low immunity, like low immunity means if CD4 count is less than 100 for him. So these people also, once you give ART, there is immune system will reactivate and they cause some signs and symptoms. Right? Another thing is if people has any other infection before starting ART. Right? That is important. Right? For example, before starting ART, that's why you have to rule out other infections also. So if you don't rule out any other infection, just give ART, once immune system activates, it will cause so much signs and symptoms. So any other infection is there before starting ART, there is a very high risk factor. Right? And second thing is your severity of your TB disease. Right? Right? For example, not only TB, any other infection, any severity of, if TB is very severe, there is more bacterial load is there, more load of bacteria is there. Right? Then also if immune system once activated, it will cause more burden and more signs and symptoms. Right? And then is usually young age. Another is male sex. So these are risk factors for developing your iris. So what are the risk factors? If patient is having high viral load, if patient is having low immune system, or if patient is having any other infection before starting of ART, right? Or if the infection is very, very severe, if patient is having young age or male sex, all these things are risk factors for developing ART. Right? Okay. Right? So what are the different types of iris will develop is simple. For example, some infection is latent only. It is not apparent to anyone. But after giving ARV, after reconstitution of infected system, that latent infection has become apparent. That is called as infection, unmasking of infection. Unmasking of infection. Iris can be due to unmasking of infection. Right? That means infection is there, but infection is latent till now. Once immune system has regained its power, then your infection is becoming unmasking, opened up. That's called unmasking of infection. So that will lead to iris. Okay. Or other thing is because of paradoxical reaction. So what is paradoxical reaction? Right? For example, some patient has already known disease, some TB disease is there. Right? You already given anti-tubercular drugs. These anti-tubercular drugs are killing your bacteria, TB bacteria. Right? So at the same time, you are giving antiretroviral drugs also. Now his immune system has improved. So what this immune system will do, they'll act against the dead bacteria and the mount inflammatory response. That is called as paradoxical reaction. That means patient, you feel like you give ATT, patient is improving. Suddenly after introducing ARV, so patient has deteriorated because this immune system has developed a paradoxical reaction to dead antigens. So this is against dead antigens. Right? Or iris can be due to autoimmunity. That means after regaining of immune system, it is damaging your own host cells also. Or sometimes this immune damage can turn out to be malignancy also. Right? So iris can happen in 4 different ways. One is unmasking of infection, other is paradoxical reaction, other is autoimmune response, other also malignancy. Right? In unmasking of infection, what is going to happen here? Already infection is there. Right? That infection has become apparent. Right? And this is because of viable replicative antigen. What does it indicate? So in your body already TB bacilli is there. It's a viable, it's a replicative antigen. So once your immune system has become activated, it mount immune response. And this paradoxical reaction is always because of the dead antigens. Usually dead antigens, the immune system won't do anything. But because of activated immune system, it will act on your dead antigens also, producing paradoxical reaction. Right? And sometimes can progress to autoimmunity, sometimes progress to malignancy also. Right? Clear? So simple thing. So once you give any patient of antiretroviral drugs, his immune system will improve. Once immune system will improve, how it acts on different things, it will manifest as iris. For example, if patient has some latent infection, after immune system is improving, so it will act on that latent infection and that infection will become apparent. That is called unmasking of infection. It is mainly because of the viable replicative antigen. Right? Or your immune system will act on the dead antigens only. That is called producing paradoxical reaction. Right? Or immune system will turn out to be autoimmunity and rarely it will become malignancy also, like B cell malignancy or T cell malignancy, all these things. Right? So the different forms of iris. Right? Now let us see one more important point is what are the different DDs for iris? What are the different DDs for iris? So what I said, in HIV positive patient, once you give ART, after ART the patient is developing some signs and symptoms. So that is what is called as iris. So I can say any new opportunistic infection can also present. We cannot know. The patient develops some signs and symptoms. How can you say it's iris? It can be any new opportunistic infection also. Right? Or whatever treatment is given, the treatment is not working. A treatment failure also can present as a new signs and symptoms. Right? Or what your side effect of antiretroviral drugs. You give antiretroviral drugs, they produce some side effects that also can be taken as some new signs and symptoms. So all these 3 things are DDs for the iris, either new opportunistic infection or treatment failure or side effect of ARVs. Right? So then how will you diagnose based on ruling out these differential diagnosis? How will you diagnose iris? There is no diagnostic test. Only diagnosis, clinical association, only clinical diagnosis. Right? So in the clinical diagnosis, first important thing is temporal association. Temporal association. So what is temporal association? As we discussed, after starting ARV, within 6 weeks, patient will develop symptoms. That is the first temporal association. That should be there. First point should be there, right? And second thing is what we discussed. So because of this ARV, immune system is developed. That immune system is mounting some inflammatory response. That inflammatory response is causing damage and producing signs and symptoms. That means suddenly patient will have high grade fevers because of your inflammatory response. Patient is having high grade fevers, right? Or some known healed lesions are going to again reappear, right? Or increase in the lymph node size. For example, TB lymph node. Okay, you're treating TB lymph node size is decreasing. After introduction of ARV, again new lymph nodes has come, or the TB lymph node size has increased. This also you can say, right? Or in any liver or something, new granuloma is formed. There is also again inflammatory response. New granuloma formed. Right? Or suddenly in new pleural effusion has developed. Right? For example, you're treating CMV retinitis. Okay? CMV retinitis patient is improving only. You are giving ARV. Now newly patient will done again uveitis. Again some retinitis worsen. So this again you can say is iris. Right? So this is the thing. So clinical diagnosis only, the first point you have to establish is temporal association. What is temporal association? That is after starting of ART, within 6 weeks patient is developing symptoms, and that symptoms are because of exaggerated inflammatory response. That's a patient with high grade fever, or already healed lesions are becoming reappeared, or already increased lymph node size, or again new lymph nodes are appearing, or any new pleural effusion is developing, or in the liver some granuloma is developing, right? Or any CMV retinitis are developing into uveitis or any new retinitis. Then all these things you can consider as iris. Right? Okay. So for this reason only you have to know what is the side effects of different ARVs. Okay. So different ARVs side effects based on you can rule out again side effects of these things. Right. So out of all the iris and all, the most serious are following TB and following CMV. That means what? For example, patient is having TB. Right? You gave ARV. Now this immune system has improved, then it causes some inflammatory damage against TB antigens. That is very, very severe. Same way again CMV is very, very severe. That's why before starting ART and all, you have to definitely rule out these things. Right? So how will you reduce this thing? So how to reduce? The first thing is early recognition of the disease. Early recognition of HIV. So how will it reduce? If you recognize HIV initially his CD4 counts will be more only, right? As we discussed, if the patient CD4 count is less than 100 only, the chance of developing iris, right? But if you diagnose HIV early only, his CD4 counts will be more than 200 only. So then if you start ART, there is less chance of developing iris. So please early detect the HIV virus and early start the treatment when CD4 count is not declared yet. That is the first thing. Second thing is screen for opportunistic infections. And treat them. That's very, very important. Right? So screen for opportunistic and treat them. That is important thing. Right? So by that also you can reduce. In this important thing is, the first thing is for tuberculosis. So if patient is having tuberculosis, so that is important thing. Again, important guideline here. So first start the patient on ATT. Right? Give 2 weeks time. Then you can start ART. This is the guideline saying. So why? For example, patient is having some tuberculosis. Right? So patient is having HIV also, patient is having TB also. Opportunistic infections, TB also. Right? Now without giving ATT, if you give only ART, what will happen? ART you have given, his immune system will develop, his immune system is regained. Now immune system will see most of the tubercular bacillar load. It will mount inflammatory response that will cause iris. But instead if you give ATT, what will happen is ATT will reduce the tuberculous bacterial load. Now after 2 weeks you are giving ART, now your immune system will get regained. That immune system will see only limited bacterial load. So less inflammatory damage. So iris chance of developing is less. So clear? Clear? So what we are doing is screen for opportune patients and treat. In the case of TB, you have to first give ATT, then you have to go for ART. So this is a major important point. In the case of HIV plus TB, first give ATT, after 2 weeks you can give ART. Right? So what is the basic principle behind this? If you give ATT, it will decrease your MTB load. Now, if you give after 2 weeks ART, this ART will improve immunity. Okay, even though immunity is improved, now only MTB load is very less, so less inflammatory response is generated, so iris chance developing is less. So that is the basic concept. Right? Again, here one basic important thing is here, ATT is there any TB, like for example any TB like TB lymph node TB and all, you have to give ATT, then after 2 weeks you have to give ART. But except in the case of TB meningitis, ATT you give, after 4 weeks only you start ART. This is very important. Again, one more neat assess question. Right? To prevent iris in a patient of HIV with TB, first you give ATT, after 2 weeks you start ART. But if patient is having TB meningitis, you have to wait for 4 weeks to restart ART. That's an important concept. Right? Right? Okay. And one more thing, again, if patient is having some cryptococcal meningitis, right, first start antifungal, then wait for 4 weeks, then you start ATT. This duration is very important. Right?
Sir, ATT or ART?
Sorry, ART. ART. Antiretroviral therapy. Right? Next, if patient is having some CMV retinitis or CMV any infection is there, again give your ganciclovir, that's antiviral. Then after 2 weeks you start your ART. Right? Remaining and all, whether it's a bacterial pneumonia or anything, bacterial pneumonia or your pneumocystic pneumonia, all these things, first treat the disease, then only you start ART. Without treating, don't start ART because it will cause inflammatory damage. Right? Right, important. And one important point is, for example, many patients having some skin conditions are there. HIV patient have skin conditions, or HIV patient have some mycobacterium avium complex infections and all. For these things, you start ATT, you start ART immediately. So what they think is like, because these things are happening because of HIV infection only, if you start ART, it will respond immediately with the ART only. So this is only exception, this thing. Okay. Any skin conditions like any skin dermatological manifestations are there in HIV positive individuals, or any mycobacterium complex infection is there. So don't think like first I have to treat infection, then only I have to start ART. So what the thing is like, it's due to because of disease process, you start ART, then because of ART it will disappear. So that's it. So this is very, very important thing. Right?
Sir, then separate mycobacterial treatment is not needed for MHC?
No, not needed. This mycobacterium complex, like some you will give clarithromycin and all, so but that nothing needed. So what the thing is like, just only this is atypical, not your typical mycobacterium tuberculosis, your mycobacterium complex, those things. Only this is the exception. And one more thing we forgot here is again toxoplasmosis. 5th point, toxoplasmosis. Right? If patient is having toxoplasmosis, treat this toxoplasmosis. After starting treatment, 6 weeks again you wait, then only you start ART. Very important, this 6 weeks. So this time duration is very important. So for ATT it is 2 weeks, but TB meningitis it is 4 weeks. Right? For cryptococcal meningitis again antifungal, then 4 weeks ART. CMV, ganciclovir 2 weeks ART. Toxoplasmosis 6 weeks. After that ART. This time is very important. Right? This is what they are asking also in exams. Right? Apart from this thing, So what we discuss, how will you reduce this? You discuss one reduces early detection of HIV and start treatment, and then you screen for the opportunistic infections and then treat them. So after treating them, then you start your ART, right? And the last is like, for example, if any patient develops iris, how will you manage this thing? So iris can classify into mild, moderate, severe, very severe, right? So after starting iris, after starting ART, some mild, moderate, severe and very severe are there. Right. So one important point I will discuss, mild is a simple, mild and all you will do just observation only, right? Moderate also only observation, everywhere you will just observation only. Okay. In severe, very severe is there. Only thing in this you have to give steroids. The first thing is 1.5 mg per kg for 2 weeks, then followed by 0.75 mg per kg, then slowly taper down, right? And the last crucial, very important point is this very severe means life threatening. In this condition, apart from steroid, you have to stop antiretroviral therapy. Very, very, very important. But this is the only indication to stop antiretroviral therapy that is very severe. That means some life-threatening conditions are there, right? Iris can manifest in mild, moderate, severe, very severe. Mild is just some mild forms, moderate some mild form, severe and very severe are there. So this moderate and mild, these are some local reactions only. These are local reactions like that. So severe is some systemic reactions also developed. Very severe is life-threatening complication has developed, right? Nowhere you will stop ART. Continue ART. Here also continue ART. Here also continue ART. Only in the very severe form you will stop the ART and give steroid. In the severe form you continue ART and give steroid. That's it. So this is all about iris. Very important question again, right? So just discuss this iris once. We'll go with the. So just keep your pen down. Just remember, just listen to the iris. Very important. It's an immune reconstitution inflammatory syndrome. So what is going to happen is, any HIV positive patient, usually their immune system will be decreased, right? Any HIV positive, usually immune system will be decreased. So once you give antiretroviral drugs, their HIV virus will be decreased. Now immune system will be improved. Now this improved immune system, how it acts on different infections, that is what is called as iris, right? So if patient is having some infection which is latent, now it may become active. Or patient is having some mild infection, now it will become severe. Or patient is having some dead antigens, it will become paradoxical response. Or nothing is there, your immune system will act on your host antigens only, producing autoimmunity. So this is what is called as iris, right? So reconstituted immune system, how it is causing damage to the body, that is what is called as iris. So what is the proper definition? The definition is, it is worsening signs and symptoms of known infection. Already patient, you know that patient is having some known infection. For example, patient is having TB, you are giving ATT also, but you started ARV also immediately. Okay, so now after immune system has developed, it will cause worsening signs and symptoms. It will go high grade fevers and new pleural effusion and new lymph node development. That is called worsening signs and symptoms, right? So already known infection is there, that infection has signs and symptoms worsen. Or already latent infection is there, it will develop into a disease. So after introduction of ART, within 6 weeks, because of your reactivation of immune system, that is what is called as iris, right? So what are the risk factors for iris? Basically, any patient who is having high viral load or low immune system. Low is that CD4 is less than 100. So for these systems, if immune system once activated, it will cause damage to the body, right? Or anything before starting ART, if any infection is there, definitely there is a chance of developing this thing. And that infection is very severe, like more bacterial load is there, then also there is a chance of developing this thing. And young age and male sex are the other risk factors for developing iris, right? So what is the iris? Can because of this unmasking of infection, that is because of your viable antigen, or paradoxical response because of dead antigen, or it is autoimmunity, or it can turn into malignancy also. So what are the DDs? Once you start antiretroviral therapy, patient is having signs and symptoms. So there can be new opportunistic infection, or because of treatment failure, or because of side effects of your antiretroviral drugs, right? So how will you diagnose? So diagnose always clinical. It's just you should establish a temporal association, that is within starting of ART, within 6 weeks patient is developing symptoms. And what are the symptoms? New onset of high grade fevers, or new lymph nodes appearing, new lesions that are appearing, or new granuloma that is developed, new pleural effusion that is developed, or any some CMV retinitis, uveitis and all developed. Right? Of this, most serious are TB and CMV. They are very serious things. Right? So how will you prevent? So first, recognize the HIV very early and give antiretroviral drugs even when immunity is not declined yet. And second thing is treat all recognize all the opportune infections and treat them before starting ART. Right? So the duration should be very important. For TB, you have to give ATT. After 2 weeks only, you have to start ART. But if TB meningitis, 4 weeks you have to wait. Right? Similarly, in the case of toxoplasmosis, you have to wait for 6 weeks. For this cryptococcus, you have to wait for 4 weeks. For CMV, you have to wait for 2 weeks. Right? Any some skin lesions and all, you can start ART, no problem it is. Other than any infections as like diarrhea, is there pneumonia, is there, first treat the infection, then go for the ART. Right? So the high risk can present as mild, moderate, severe, very severe. So mild is just only some mild, some enzyme elevations like that can be there. Moderate is some local reaction. Severe is some systemic reactions. Very serious, life-threatening conditions. In all these conditions, no need to stop ART. Only in the life-threatening that's very severe, you have to stop ART. Right? And in severe and very severe, you have to use steroids. That is 1.5 mg per kg for 2 weeks. Then 0.75 mg per kg. Then you have taper. Right? Why you are giving steroids is anti-inflammatory or reducing the inflammatory robust response. Right? Clear? Any doubts?
No, sir.
Yeah, this iris is very important again. Right? So remaining class will continue tomorrow. What else thing iris we discussed? Where is iris here? Okay. Iris we discussed. Right. So tomorrow class very important is drug resistance and what is the treatment failure and what is HIV plus TB co-infections, what you do in pregnancy, what is post-external prophylaxis, everything is important. Right? So we'll stop the class here. Tomorrow we'll meet again.
Okay. Thank you.
Thank you, sir.